Hello and welcome to DIY Therapy. As always, we'll start with our disclaimer. This podcast is for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. My name is Will. With me, as always, is Andy. What's up?
Not much. What's going on?
Oh, not much.
We live such exciting lives, let me tell you.
Well, when you have 3 kids, I guess the exciting thing is my youngest, who is my son, his birthday is coming up, so
cool.
He's super excited about that.
And Ellie just turned 8.
Yes,
so
I saw that.
Something did happen this week. Did get an email from Sam's teachers, my 4-year-old,
who is notoriously
go ahead.
ADD.
You forgot the H in there. The ADHD.
Just like
the hyperactive is really the big one. Yeah. So he apparently had a bad day, and their policy at the school is not. They
don't do timeout or anything like that.
Well, they don't. So we got an email that said if it happens again, he may be suspended for 2 days. And I'm like, so we go down there, and so I took off work to go and talk with the teacher. I'm like, he's 4, right?
What could he do?
And what did he do? And we had never had any discussions about his behavior before. And she's like, yeah, well, he had a really bad day. He was in 4 timeouts in the morning. Okay, trying to compose myself. He's 4, right? Like they have bad days. Yes, but if it does happen again, he will be suspended. So he didn't hit anybody.
No, okay.
He didn't verbally abuse any teachers. He just wasn't listening and was in timeout for 4 times in the morning. Yes. Mm-hmm. Okay. All right. So I ended up writing a very thoughtful email to the director.
Yeah, as you should.
And just asking if they could. If there could be a discussion first with the parents so that we can put together like a behavioral plan so that we could discuss how we can try to work on Sam. Because we don't want Sam to be a bad kid, obviously. But on the other hand, he is 4. And when we asked him, this is the greatest part, when we asked him how his day went that day, he goes, "Oh, I had a good day." He had no idea. He had no idea. He's not trying to be deceitful. He had no idea. He's like, "Oh yeah, I had a good day." Like, okay, and this is where we're at.
There you go.
So that was exciting this week.
That's funny.
Yeah. Anything else for you? Just the birthday's coming up?
Just that.
Yeah, that's cool.
That and we had a wedding to go to this last weekend, which was a lot of fun.
Oh yeah, Mandy stalked your Facebook. She saw that you were. She's like, "What wedding were they at?" I'm like, "I don't know."
Just a friend from college.
Yeah. Cool. Awesome. So what are we talking about today?
Chronic pain myths.
Dun 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 dun.
Well, it's not necessarily. I wouldn't call them myths. It's just the things that people believe. So
yes.
To me, a myth is something that's patently untrue. I would say.
Yeah, I mean, like.
So none of these are.
They're just. None
of these things are not necessarily untrue. It's just they're not the most common. Not the most true.
They're not always correct. Let's put it that way.
Yes.
Because occasionally some of these...
but I mean, like I said, you shouldn't rely on any of these things.
Yeah, and everything that we will talk about here, there probably is a silver lining that some of it could be applicable.
Yes.
Okay? But in most cases, it's not necessarily true.
No.
Yeah.
So we have put a lot of, as a society, Western medicine, we put a lot of like balls into the court of...
About the things we're about ready to discuss.
Yeah. People believe that, this will be the end-all solution.
Yeah. And in fact, sometimes they can impede and or hamper healing.
Right.
By avoiding these things. So that's one of the reasons why we're actually wanting to discuss this, is so that people just have a better knowledge of, okay, this is the common belief that's out there, but, really what research and what we found through both anecdotal and as I said, research, it just isn't. It doesn't hold water. It's not true. So, I think the first thing we should probably do is define what is really chronic pain. And quite frankly, this is this isn't just applicable for chronic pain. It is applicable for acute pain,
As
long as your pain is manageable. Okay.
Yes.
So let's just start there. If you've just injured, say your back, your elbow, your shoulder, your neck, whatever, right? There is always a period of time where if the pain is really unbearable and the pain is extremely volatile, it doesn't take a whole lot to set your symptoms off. It doesn't take a whole lot to make your symptoms extremely irritable. Then there is a time where you do probably need to do some rest, avoid a little bit of things, relax, let everything calm down, and then you can kind of move into some of the things that we're going to talk about here in a bit. But, typically the acute phase of any kind of healing process is really anywhere from 24 to, I'm going to say 96 hours. Okay.
Yeah.
Then you move into more of the subacute phase, which is really anywhere from, and that's where, you can move. The pain doesn't necessarily get terribly out of control with movements. There's certainly a threshold to which you shouldn't kind of pass, or a barrier which you shouldn't continue to push through. But symptoms won't go wildly out of control too quickly. And that can be anywhere from like a 4-day to, say 6 to 8 week period. But once you get past that 6 to 8 week period, you're starting to move into that chronic phase.
Right.
But I think most of these myths are actually pretty applicable for the subacute, that middle phase, and the chronic phase.
Yes.
Do you agree with that?
I agree with that, yeah.
Yeah. So myth number 1. Go ahead.
Oh, yeah.
I've talked too much already.
A scan will give me a diagnosis.
Dun, dun, dun.
I feel like this one, of all of these ones, is kind of misleading.
Very much so.
Because sometimes it will give you a diagnosis. It may not be the diagnosis that is causing your pain.
Yes.
But it will give you a diagnosis.
So a little background information on this. It actually, research recently within the last 5, 6, 7 years has indicated that people who have more and more scans, one, their cost overall goes up to what they're spending on their dysfunctions, and the length of time for recovery actually gets prolonged, okay? And they report worse outcomes, and they typically will have longer standing pain or chronic pain that lingers throughout maybe possibly months to years to decades. So what Will was kind of alluding to just a moment ago was that, if we x-ray, if we MRI any structures in our body, if we're over the age of 25 to 30, so definitely 30 plus, we're going to find things wrong.
Right.
Okay. What there is
most notably is usually arthritis.
Yeah, arthritis. Like that's kind of the go-to for the docs when they don't really know what to maybe label it as.
Yes.
And so they get an X-ray. X-rays only show bones. They don't even show soft tissues. And they go, oh look, there's a little bit of arthritic changes. Arthritic changing is normal as we age. It's extremely normal. In fact, it's weird if you don't have any arthritic changes. Yeah. So to say that someone in their 50s has mild to severe mild to moderate arthritis, and they have back pain or neck pain, and to label it as, oh, this is arthritic changes, well, you know what? If everybody with arthritic changes had if there was a direct correlation between pain and arthritic changes, well, then everybody in their 50s would have it, because everybody has arthritis. So it's just really important to understand that you're probably not going to get either a specific diagnosis or an accurate diagnosis from a scan. And what is really important is how you clinically present.
Yes.
And that is really how you treat people, okay? That's how we treat people. That's how the best clinicians in the world treat people. It's really looking at daily activities, what it is that they are doing on a regular basis that are driving the symptoms, looking for those patterns, and what's actually showing up on your scan really has, in some cases, obviously, yes, it does, there is value to that, but in the majority of the cases, there isn't.
Yeah, like when we're talking about like when it's applicable, is like ACL,
yeah,
those kind of things, like definitive, like my knee's screwed up. I just had a terrible, running, whatever. And my knee bent the exact wrong way. Let's take a look at it.
Yep, definitive
like that. If you have just random back pain and you get an X-ray for it, it kind of doesn't tell us anything. Mm-hmm. Yep. At least from our point of view.
Yep.
It'll give the doctor, I don't want to say ammunition, but it will give the doctor something to point at and say, here's what's kind of causing your problem, probably on your way.
Yep. All right, myth number 2.
It is.
I am causing pain if it hurts. Absolutely. No, that's not true. No,
you're causing damage if it hurts.
Oh, I'm sorry, causing damage if it hurts.
I was causing hurt if it hurts?
Yeah, well, that's me not being able to read. Thank God you do the intro.
And I nail that all the time.
All the time. We don't have to do 3 or 4 takes every time, no.
You don't even know how many times I edit it when I...
Seriously?
No.
You go back and you have to edit again?
No, I don't edit anything.
Oh, okay. All right, so the idea is that there's a direct correlation between pain and damage.
Yes.
Okay. And also not true. Okay.
Yeah. It kind of goes back to almost the X-rays and imaging. Because I've had... how many times have you had a patient telling you, oh, my knee is arthritic and it's gonna they're under the impression that it's basically gonna 2 steps and they're gonna crumble into dust like a vampire in a Buffy the Vampire Slayer or something.
Wow, weird reference.
What are the ones that they turn into dust? I mean,
it's okay.
I don't know.
It's okay. Yeah, I mean, one of the examples that I always use with people is that, and there's a great chart that actually occurs with this that maybe we can find and post. But most, like if you look at like professional athletes and when say they tear their ACL or when they tear say an Achilles tendon or a pitcher that all of a sudden grabs his arm after throwing, most issues that occur prior to, most actual like real structural damage, there's no pain that occurs prior to that structural damage because the tissue will actually become overstrained way too quickly and then you don't experience pain prior. Pain is actually an alarm in our body that when you're approaching repetitive stress, repetitive strains, it's letting you know that if you continue to do this, you can cause damage. Yeah. But it is not a direct correlation to pathology or damaged structures. And that's extremely important to understand because if you can slowly work that pain, if you're having issues, then you can slowly work through it. You shouldn't continue to just push through pain. Doing that can cause some structural damage.
The no pain, no gain is not necessarily.
Yeah, it's not really that it's not really applicable. The other aspect of this that I think is always important to really understand is that, as I said earlier, pain is not directly correlated to damage, but pain is directly correlated to sensitivity. So tissues can be extremely sensitive but not damaged. Okay, so that's why we can change that sensitivity by working into it slowly and not pushing through it too quickly, and that's really more of what pain is associated with versus actual damage.
Yes.
Yeah.
I was trying to think of a way to maybe kind of clarify that, but that's pretty.
Yeah. I don't know what another good example is.
It's sort of like, I guess, like a sunburn would be a good way of...
Yeah, there's no structural damage to the skin.
I mean, I guess there is. It's a mild burn, but it's like... It's
sensitive.
Yes, it hurts because it's just really overly sensitive and it will heal. But
well, the idea is there is a slight burn, but think about when you get a sunburn and then you all of a sudden take a shower and that hot is not actually hurting the skin or making it worse.
Yeah, it just feels. Yes, there.
But it's a sensitivity issue.
Sensation. Mm-hmm.
Sensitation issue. I speak well. All right. Myth number 3: bending and lifting will make my low back pain worse.
Definitely not.
No. In fact, this is something that I talk to patients all the time with. There is nothing wrong with bending or lifting. It's one, where are you at in the whole pain cycle? And if it is extremely sensitive at this point in time, you may want to avoid it for a bit. But once we get into that chronic stage of things, it's not necessarily the amount of bending and lifting that we're doing. It's the amount of it's kind of the ratio of how much we're bending and lifting compared to other exercises that can give you some relief.
Yeah.
Okay. So it's not that, let's say that you have a disc injury and somebody...
Which, again, MRI will show after a certain age you will probably have
a disc injury.
Yes.
Yeah. But sometimes disc injuries are the direct cause of pain, right? And so there are times where maybe we need to avoid those for a bit. once we get out of that, really large pain cycle, though, it's not necessarily, bending forward is going to break your back. If you do it too much, you can cause further injury, but it's about balancing that. And that's really life in general, about balancing the strains and stresses that are being put on the back. And it's more along the lines of what ratio you're bending forward to bending backwards, or vice versa.
Right.
If you've got an arthritic problem that's causing you pain in your low back, well, the more you extend backwards is typically how you're going to bring on your symptoms. So maybe we need to actually bend forward a little bit more. Mm-hmm. So there's certain patterns that we see, but it's really about finding that nice balance.
Yes. Yeah. Which is sometimes you're too close to it and it's tricky to see for yourself, which is, why something like physical therapy or signing up for one of our wellness consultations is a nice way to kind of...
Shameless plug.
Wow.
No, actually, you'd be surprised how many times I've talked with people with a certain problem. They go, "Oh my gosh, this is so obvious. Why didn't I see this?"
Yeah.
Because it's too personal.
Yeah, it's too
we're
close.
Emotional about it. As much as we want to think that we're looking at things objectively, it's just too personal.
Yeah.
So, it's one of those things that sometimes you need some outside eyes looking at it. Myth number 3.
This one's my favorite. I should stay in bed and rest.
Well, in the 1990s.
I know. The funny thing is, a lot of these things were not too far outside of actual research showing that, no, we were doing it wrong.
Yeah, I mean, in the 1990s, you hurt your back and you're in traction for 6 weeks. Mm-hmm. I mean, you're in the hospital. They get a bed for you and put you in traction for 6 weeks, which is nuts. Just nuts. But no...
Actually, you want to think of something nuts, do the math on how long ago 1990 was.
Oh, well, I can't do that. That's like... It feels like it should be yesterday, but when we start counting the date... Oh, God.
Wait.
I'm old.
Nope. Nope.
Crap. Shoot.
Yeah. That's one of my favorite ones, because if resting solved it, then nobody would have any problems.
Yeah, well, yeah, exactly. The truth is, the more you move, the more... Now, you shouldn't push through pain, but the more you get up and move and get into that normal habitual pattern, the more you're going to create some positive input, okay, to the system, to the nervous system, to the brain, that's going to allow that tissue to desensitize or the sensitivity to drop. And as we said, most pain is actually correlated to sensitivity levels versus actual tissue damage. So if we can provide those good, normal tissue just inputs, movements, etc., that don't provoke pain, then or don't provoke a lot of pain, I should say, then that will actually help us kind of get through and move along. But if we just sit there, then the moment that we start to move, we'll end up starting to have a lot of pain, which then kind of cycles us into wanting to sit more and more, because that's the only time we feel good. So you can really get into the cyclic pattern that can be...
It's an easy one to fall into.
It totally is. And I get it. And even we've talked about it on this podcast before. One of the first things that we tell people is, well, if it's really hurting, we do have to avoid for a bit. But then you have to introduce activity.
But yeah,
it's a fine line.
Yeah, it's a really fine line.
It's a gray area, and that's sometimes why you need people to talk to, and it's hard to manage on your own.
Yeah, because otherwise you'll just fall into the trap. Well, I'm just going to sit.
Yeah, exactly. All right, next one.
Strong painkillers, like opioids, will help manage my pain. They don't manage your pain.
Yeah, in this one, I am always kind of...
well, because I say they don't manage your pain because they just mask your pain.
They mask your pain. One of the things that I do believe about pain medicines is that if we are really cycling through those very, very high pain patterns, sometimes an NSAID, a non-steroidal anti-inflammatory drug, or an opioid to help get things calmed down can be beneficial, but we have to then move and not go to that last minute.
The best example is like when somebody has a new knee. We were very adamant on make sure you stay on your medication
so that you can move.
Yes,
so they should be used in conjunction with things. They shouldn't be used just, I'm going to just use my pain meds and then do whatever the heck I want, or I just plan on doing this long term for the next 12 years of my life, staying on pain. That's not a good management plan.
No.
But in conjunction with the proper strategies, they can be helpful. But again, a lot of people, if we avoid some of these other myths, we can avoid some of the other some of the pitfalls of opioids. And this is a big one too, just because of the opioid epidemic that is, thank you, not academic, epidemic that is out there right now. There's a lot of abuse, and I think in the last 10 years or 10 years ago, many doctors' choice of first line of defense was opioids, and so that's led to a lot of problems recently, and a lot of addiction and public awareness, and then also now going the way opposite of we can't prescribe anything.
Yes, I think it's the problem is with this is we do these hard swings.
Yeah, the pendulum swings the opposite direction.
So there's a definitive middle ground that is always
that's okay. Yeah. So have those conversations with your doc. Okay?
Yeah, I mean, how many times have you had patients, especially in the new knees, they're afraid of becoming addicted?
Oh, probably 2/3 of my patients.
So I don't want to be addicted. You'll be fine. You'll be fine.
Yeah. All right. Let's see. Last two. There's two more.
Surgery is my only chance of improvement.
No.
That's. I mean, going back to a knee, maybe, but
sure.
Back.
No, in fact, I had a conversation with a gal about 2 weeks ago who was coming off of a back surgery, and she was just questioning herself, did I make the right decision? Did I not make the right decision? And she, in turn, had, let's say a back or a neck. Only about 3% of all back injuries and or neck injuries are actually surgical candidates. But there are really some pretty hard and fast rules on when people are or should actually go for surgery. One is if the pain is truly unmanageable and you've gone through, therapy.
It's literally your last line of defense.
Yeah, it's last line of defense, and you can't live with it anymore. Okay, absolutely.
It's
give it a shot.
Yeah, it always seems like a roll of the die on whether it helps or not with people, and there's no rhyme or reason on why it would help one person and why it doesn't help another person.
Yeah, and then the other couple for like a spine would be, whether or not you had hard neurological signs, which is basically like loss of bowel or bladder function. That means there's compression on the spinal cord itself. Whether or not you had lack of deep tendon reflexes, lack of coordination, and or whether or not all of a sudden you start to have significant muscle wasting and or muscle use, and those are all hard neurological signs, meaning that if there is significant compression on the nerve, and if you don't relieve the pressure on the nerve quickly, then it could become permanent. So those are surgical.
But those are really uncommon.
They're not very common at all. Okay.
Yeah, your sciatica that you have sucks.
And it does.
It does suck, but it's not these. These things are
these things are typically very distinct.
Yes.
Okay. Now that doesn't mean that you don't get surgery or that the doctor doesn't recommend it, but truthfully, those are the only ones that have to. So, I mean, you've just got to be aware of, have I gone through the process? Have I been open to the process? Have I believed too much in some of these other things that we've discussed here in earlier in the podcast here? What are my thoughts and beliefs? Can I get over some of those things? Am I taking the right approaches to these things? Because a lot of people can get their symptoms and pain very much manageable prior to surgery and can avoid it.
Yeah. And a lot of times we're not solving it all the way. But it's just getting it to a point where it's totally livable.
Yeah, and even to that point, there was I tell this story to a lot of patients that come in and say, I'm coming in because I've got a knee replacement that's scheduled in a few weeks, and doctor wants me to try this, and they don't really have a whole heck of a lot of buy-in to it. And I share with them a research study that was shown that actually showed they took surgical candidates, people who went to the physician, the orthopedist, and they said, yep, absolutely, this is a surgical candidate. They then took, for a knee replacement, they then took these people and they took them through a 12-week strengthening program and kind of talking to them about pain and sensitivity, a little bit of pain science education, and they took them through this program. And by the end of the 12 weeks, these absolute surgical candidates, only 1 out of 4 still elected to have the surgery.
Yeah.
Which is it was a pretty compelling
argument for the
and research paper that indicated that, hey, there are other options out there if we work at it and if we put in the energy and effort. Now, if you want the quick fix for knee replacement, okay, it's there. That is a fantastic.
I wouldn't say it's a quick fix. It
stinks.
The recovery process of it afterwards is at least that.
Well, but it is one of those things that once you get beyond that, you really don't have to work at it all that more.
No, that's
all
true.
that much more. But and the outcomes are fantastic.
Yes.
You know, I mean, it's the best surgical. It's the best orthopedic surgery outcome procedure. So, all right, last one.
Last one is my pain and limited function mean there's nothing I can do.
Nope.
No, that's definitely that's kind of sums up everything.
It kind of ties into everything that we've already talked about. You know, you've got to find a baseline that you can tolerate, and then slowly expand upon that, and then let your body become resilient. If you have decreased function, if you have increased pain, let your body become resilient to those baseline movements, and then slowly expand from there. And it might be a 3-4 week process before you even start adding in more exercises, but certainly there's a systematic way that you can start to actually build people up. I have a patient that sees me probably every 3 years or so, and I saw her. I actually did an evaluation with her yesterday, and she has severe fibromyalgia, and what ends up happening is she gets so deconditioned, she has so much pain that she gets in these cycles where she doesn't move for months, weeks, and eventually she, just gets in this cycle where all of her pain gets out of control. Well, we have to start at very, very basic things, get her used to it, and then we slowly, over the course of like a 6-8 week period, just keep adding an exercise or another 5-10 reps of an exercise and just keep expanding it out. And she comes back each time because we get her back to her prior level of function, but she eventually doesn't maintain. Yes, or there's an incident that occurs that makes her have a huge setback, and she doesn't have the wherewithal or the motivation or the confidence, maybe is even a better term, to kind of take it on by herself.
To understand, I've been through this several times.
Yeah.
I know the steps.
Yeah, and I have no problems. She's very pleasant. I have no problem seeing her, and I have no problems taking her through all those issues. But that's a perfect example of someone that follows this last myth, and we see it all the time. And, so I think that would be a good time for a little bit of again, shameless plug. We do have DIY therapy consultations that you can do with us. Email is
DIYtherapy206@gmail.com.
Yeah, where if you are having some issues with either chronic pain, acute pain, whatever, we can help kind of talk to you about, how that pain influences your lifestyle, how your lifestyle influences the pain, and try to find a nice blend there to get you through some of those issues.
Yeah, nice, simple. You can do it from your home.
Mm-hmm.
I don't think we're too painful to talk to.
I know I am. I am very painful.
I never talk to myself.
My wife tells me that all the time.
Well, that's different.
Not really. I think she likes me.
Well, she hasn't left you yet.
Yeah, that's a bonus. I think it's the kids that are holding us together.
It is always an option. Is
it?
Speaking of Mythbusters, their tagline is "failure is always an option." So I mean, yeah,
okay, I'll take that.
Yeah. Do you want to take that?
Yeah. All right.
Wrap it up. This podcast was for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. Remember, treat yourself.